And we're back. Thanks for staying on. South Africa is working to clear a burdensome backlog of 175,000 surgical procedures in its health facilities. Many of these were postponed because of the COVID-19 pandemic, and most of the delayed operations are orthopaedic and gynaecological surgeries, and the waiting time is said to be ranging between 2 weeks and 7 years. The National Department of Health says theatre hours are being extended to include weekends to reduce the backlog. Joining us now to explain strategies is Professor Kathryn, Director of the Center for Global Surgery at Stellenbosch University. Prof, good evening, and thank you very much for your time. It is understood, of course, that during COVID-19, some of these surgical procedures were put on the back burner, but of course things have since then opened up. Are we saying very little, or whatever effort that has been put in has just not been adequate enough?
Yeah, thank you for having me. So I think the first thing to understand is that operations or surgeries in South Africa were really sort of hanging on by a thread. So even before the COVID pandemic, many elective procedures were postponed only because there wasn't capacity at our public hospitals to take care of them all. And what COVID did is really unmask the problem. Because elective surgery essentially came to a grinding halt for 2 years, the backlog got much, much worse, and I think that really has highlighted the situation.
Yeah, and as far as the capacity question then is concerned, I mean, what has been the conversation around how we boost that? I know the conversation now is to extend hours, but I hardly see how extending working hours would overall address this question of a lack of capacity, as you put it, that has been historical.
Yeah, I mean, I think the longer-term problem or the bigger issue is that most of our surgical capacity in our public health system is clustered around the bigger urban hospitals, so what we call the regional and the tertiary hospitals. That means that the district hospitals, which are more common, there's 200 and some district hospitals around the country, and those are located in urban and in rural areas where much of our population lives. Those hospitals don't have that much surgical capacity. So every person with a surgical problem then needs to go to the regional and tertiary hospitals. And so they just don't have enough capacity. So certainly we're limited by the number of operating theaters, but also by human resources, by manpower. And specifically nursing has come to be a big shortage, and that has limited the amount of surgery we can do. Now, post-COVID, or sort of post the COVID intense outbreaks, now we're trying to return to business as usual, but now we have over 100,000 operations backlog. And whilst extending theater hours can be one strategy, it's certainly not going to reduce all of the backlog, especially since we already have a human resource crisis. And so even if you extend theater hours, you still need to find the staff to man those theaters. Also, you know, we're limited by our theater beds, our ward beds, our inpatient beds, because after surgery, a patient needs to recover, sometimes in the intensive care unit and sometimes just on the regular wards. As you probably know, our incidence of trauma and therefore operations related to injury is extremely high in this country. And often elective cases are postponed by these emergency cases. And so if we don't do something to address that as well, it will be difficult to get to the elective operations.
So is 7 years a realistic time frame to put down as a time possibly when we could possibly get to all these backlogs, or is that just the time range that is currently being estimated in terms of the waiting list?
Well, I think it's really hard to say because some waiting lists for what's called the quote-unquote elective conditions. So, for example, if you need a knee replacement, that could be years currently, waiting time. Some other operations, for example, if you have cancer, the waiting times are a little bit shorter. But what often happens is that surgical conditions that are considered elective, the patient waits and waits and waits, and eventually that does become an emergency. And the disability for the patient is much higher, and sometimes even it can be life-threatening if you wait too long. So I think that 7 years in some ways is almost optimistic because I think our surgical backlog is so large now. And we, of course, have new patients with new surgical problems that we need to address, especially those with emergencies. And so some of these elective conditions may never even get addressed.
So with all the issues that you have cited, I mean, bed capacity, available human resource, and of course the trauma question that also seems to put these elective surgeries on the back burner. If we go in the current pace and the current rate at which we are doing these surgeries, of course, adding the extension of theatre hours, are we likely ever to be able to cover that backlog with just the public sector?
Well, I don't think the current strategy, or if the only strategy is to extend theater hours at the current hospitals, such as the big tertiary hospitals, is going to address the problem. I think we need a bigger strategy, even if we're looking within the public sector, of expanding surgical capacity to the district hospitals. Again, district hospitals outnumber regional and tertiary hospitals by several fold. And if we can strengthen the capacity there, it can certainly offload some of the burden from the more urban hospitals and the larger hospitals, especially these sort of bread and butter conditions that it may not take as much surgical skill or hospital capacity to address them. So some of those examples might be simple hernias, amputations, skin grafts, and sort of the orthopaedic procedures might be able to be done at district hospitals. You also mentioned perhaps involving the private sector or not just addressing the problems in the public sector. So the public and the private sector are pretty separate in this country. But during COVID, when the public sector bought out private hospital ICU beds, was a great example of how the public and the private sectors can work together. And we certainly do have a lot more surgical capacity in the private sector with waiting times that are a lot shorter. So even with the upcoming NHI, the National Health Insurance, I think that it would be important to involve the private sector, especially to try to reduce the backlog, but also moving forward, how do we deliver safe surgical quality care in a timely way to our population?
Yeah. And is there room for collaboration here, maybe even with other international partners, maybe even with other African countries that could possibly assist and lend a hand as far as the capacity that we need?
Well, I think that collaboration is always good, but I do think that we have the resources to help ourselves here in South Africa. Getting help from international agencies or institutions often is if we need manpower. So perhaps in the short run, we could have some of those specialists or folks come over. But, they don't know our working conditions. And if we're then also limited by theater time and inpatient beds, then I don't think that necessarily is going to be the only answer. I think that, in South Africa, it's sort of a redistribution of where surgery can happen. So at the moment, we have very, very crowded certain hospitals, but other hospitals which don't do operations at all. And I think it's really more looking at the redistribution of resources. And that will take political priority. I think that surgery, unfortunately, hasn't really been a health priority in this country, but up to a third of the burden of disease or medical conditions might be able to be addressed by surgery, and that's a very large proportion.
Yeah, you're saying some of these surgical procedures are less complicated surgical procedures. Just give us an idea of the scale and range of the kind of procedures that would need to be done.
Right. So we have anything from a basic sort of infection or what we call an abscess under the skin that needs to just be opened up, so just made an incision. And that is considered a fairly sort of minor operation, if you will. And certainly in this country already, many persons who are not specialist surgeons, so a medical doctor with surgical skills could address that. Then, of course, we always have to think about the anesthesia. So even if the operation is simple, perhaps the patient population that needs certain operations might need a more complicated anesthesia, which would require a specialist anesthesiologist to do that. But there are many types of operations, like an abscess, like I mentioned, skin grafts after burns or certain injuries that could be done at district hospitals, cesarean section for obstructive labor, for a pregnant woman is already done at many district hospitals. And the ability to deliver a cesarean section already requires the nursing staff, the anesthesia, the obstetricians or surgeons, the inpatient beds. And so the infrastructure in many of the hospitals is already there. We just need to take the next step to train the staff and to have the resources to do a larger package of surgical care at the district hospitals.
Yeah. How much does cost play here in terms of being a factor in terms of the backlog and what we're able to deliver?
Right. So I think cost is really important. I know I live in the Western Cape, and there has been a big effort recently now to try to address the surgical backlog, and there has been earmarked funding, which is wonderful. But I think that now that we've gotten ourselves in a situation where we're trying to do a lot extra, it does certainly cost money. But overall, I think the important thing to know is that surgical care is cost effective, and it's not always an expensive luxury item that some people might think of. But it does require long-term investment in training more human resources and allocating more funds up front. And so I think that makes policymakers nervous if you say, well, I now need quite a lot of money to reduce the backlog, but also to improve our overall surgical capacity. But I think in the long run, it would be very cost-effective to invest in these type of capacities, because then patients will get their conditions addressed more quickly, and then they won't end up in an emergency situation. It will save lives and reduce disability.
Yeah. What we saw, for example, Prof, in Limpopo at some point, they were talking of mobile clinics, for example, going to do things like skin grafts and some of those not so complicated procedures of that nature. Would something of that sort be able to, I guess, reach the rural areas where you're saying access to healthcare is quite a challenge?
Yeah, that's a really good idea. I think, though, we already have many district hospitals with theaters, but we're missing a component. We're either missing the equipment or the human resources. And so already there has been outreaches, so teams from the larger hospitals that go to one of the smaller hospitals. So the smaller hospital is missing the surgeon or the anesthetist, for example. They'll bring those resources, operate on the patients, and perhaps there are beds there that can recover the patients. In the Western Cape, that also happens. Regional hospitals offer some of their expertise, at the same time building capacity in the local staff. So the idea would be, if you go out to do a hernia repair, then there's a local doctor there who could also learn, and so that eventually they can do the operation safely themselves. I do think that the mobile units can be helpful if they're bringing the equipment as well as sort of a team with them. But often the infrastructure, the building is already there.
Prof, appreciate your time. Thanks for your intervention tonight. Professor Kathryn Chu, she is with the Stellenbosch University. Of course, concerns being raised around the backlog and what interventions would be required for us to be able to cover those 175,000 surgical procedures that still need to be conducted.